It's fascinating how some concepts we think are, well, universal, like giving fluids, suddenly reveal themselves to be incredibly specialized. You might imagine it's just a simple drip, right?
Mm.
But for certain patients, it transforms into a precise, life-saving art. And that's exactly the intricate world we're diving into today. Our mission really is to take a stack of detailed sources, everything from foundational definitions to advanced specialist guides, and pull out the most important insights on IV fluid therapy for neonatal foals. This deep dive should give you a shortcut to being truly well-informed on this critical area of vet med. And honestly, the unique physiological challenges these tiny creatures face are truly remarkable.
Absolutely. And what's really crucial to understand right from the start is that neonatal foals are absolutely not just miniature adult horses.
Right.
Their unique fluid physiology is what makes this topic so ripe for a deep dive. And this fundamental distinction, well, it's going to be the thread running through our entire conversation today.
Okay, so let's unpack that then. If they're not just smaller adults, what makes their fluid balance so profoundly different? Why can't we just, adjust adult protocols down?
Well, it comes down to several fundamental physiological differences. First off, they have a much higher total body water percentage.
Higher.
Yeah, up to maybe 75–80% of their body weight compared to about 60% in adult horses. And significantly, a larger proportion of that water is in the extracellular fluid compartment.
Okay.
This all contributes to a proportionally higher fluid turnover rate. You can think of them like tiny revved-up engines. Their faster metabolism means greater fluid losses.
Both kinds of loss.
Exactly. Both insensible through respiration and skin, and sensible, so urine and feces. This translates directly to significantly higher maintenance fluid requirements per kilogram of body weight compared to an adult. Much higher.
Right, so more in, more out, basically.
Precisely. Then there's their immature renal function. A foal's kidneys, they're just less efficient. Less efficient at concentrating urine, excreting sodium, and regulating acid-base balance. This really limits their ability to handle large fluid or sodium loads. And a key point here is their naturally low urinary fractional excretion of sodium.
Up by low.
It's normal physiology for a foal on a low-sodium milk diet. It helps them conserve sodium. But it means if you give them standard isotonic IV fluids, like normal saline, you can quickly cause sodium overload.
Oh, okay.
And that forces their bodies to retain excess free water, which is not what you want.
Got it. What else?
Another difference is their interstitial space, the space between the cells. It's more compliant, more stretchy, you could say. It can hold surprisingly large volumes of fluid. Now, this can act as a bit of a fluid reservoir during dehydration, which is helpful, but it also makes them very prone to edema, swelling, if they receive too much fluid. And this is a big one. Clinical signs of dehydration. Well, because foals are prey animals, they're masters at masking signs of illness. So those early dehydration signs, like a subtle skin tan or maybe slightly dry gums, they can be misleadingly mild or even absent until the foal is significantly dehydrated. You might not see, obviously, sunken eyes until it's quite severe.
Wow.
And by then, they can deteriorate very, very rapidly. Lastly, don't forget their high metabolic rates combined with limited glycogen stores. Meaning they're highly susceptible to hypoglycemia, low blood sugar, which needs addressing quickly.
So it's really not just a matter of scaling down treatment. It's an entirely different physiological playbook playing out. That really underscores why specialized knowledge isn't just helpful here, it's absolutely non-negotiable for their survival, isn't it?
Exactly right.
So given these incredibly unique challenges, what are the specific scenarios where these little ones absolutely need this kind of specialized fluid intervention? When do vets say, okay, we need to get fluids into this foal now?
Right. Well, the most critical and most common indication is definitely dehydration or hypovolemia, low circulating volume, especially when it's secondary to sepsis or septic shock.
Sepsis is a big one then.
Huge. Sepsis in particular can lead to widespread vascular leakage, leaky blood vessels, a dangerous drop in blood pressure, and just poor tissue perfusion throughout the body. Critical situation. Beyond that, we see it needed in cases of severe diarrhea, obviously losing a lot of fluid there, or when a foal simply can't or won't nurse.
Due weakness.
Yeah, due weakness, maybe underlying illness, or sometimes even issues with the mare. Fever, overheating, acute hemorrhage bleeding, and dysphagia, which is the inability to swallow properly, are also major triggers.
Yep.
We also commonly encounter perinatal asphyxia syndrome, often called HIE or hypoxic ischemic encephalopathy, dummy foal syndrome sometimes. These foals frequently present with a poor suckle reflex, dehydration, and often dysfunction across multiple organ systems. So fluids are key. And on top of those, fluid therapy is vital for correcting hypoglycemia, which we mentioned, balancing critical electrolyte imbalances.
Like low sodium.
Like hyponatremia, yes, or hyperkalemia, potassium, or hypocalcemia. Also managing metabolic acidosis, which is very common in sick foals. Supporting acute kidney injury to promote blood flow and urine production. And of course, sometimes fluids are needed just as a vehicle for continuously delivering therapeutic drugs like antibiotics or other medications via CRI, a constant rate infusion.
It sounds like understanding these specific triggers is paramount. It really highlights how broad the application of fluid therapy is for such tiny, vulnerable patients, and why timing is just everything.
Absolutely. Early intervention is key.
So before any fluid even touches a vein, a thorough assessment is absolutely crucial. How do veterinary professionals play detective and figure out a foal's precise hydration status, and maybe more importantly, exactly how much fluid is truly needed?
Yeah, it's definitely a multifaceted approach. You're combining careful clinical observation with precise lab work. It's not one or the other. Clinically, vets look at a foal's mentation. Are they dull, depressed, or are they bright and responsive? Is their suckle reflex strong or weak, or maybe absent?
The basics?
The basics, but crucial. They'll check mucous membranes, gum color, and capillary refill time. Looking for pale or maybe injected brick red gums, or a prolonged refill time, which ideally should be under 2 seconds. Heart rate, is it too fast? Pulse quality, is it strong or weak and thready? Respiratory rate and effort, and the temperature of their extremities, cold limbs, ears, muzzle, those are all key vital signs.
And dehydration signs.
Well, here's a surprising detail. Skin turgor, the skin tent that we often rely on quite heavily in adult animals,
Yeah.
it's actually less reliable in foals.
Really? Why is that?
Because their interstitial space is so compliant, like we mentioned, it doesn't tent as readily. And their eyes, they can appear surprisingly normal even with significant dehydration. So truly sunken eyes, that usually indicates a very severe deficit.
Wow, okay. That's important to know. So lab work must be critical then.
Absolutely critical. An elevated packed cell volume, or PCV, and total protein, TP, can be early indicators of dehydration, hemoconcentration. Blood gas analysis tells us about their acid-base status. We look at pH, but also bicarbonate and base deficit measurements, which help quantify any metabolic acidosis that might be present.
And you mentioned lactate.
Yes, and this is really telling. An elevated blood lactate concentration, say anything consistently above 2 to 2.5 millimol, that's a critical alarm signal.
What does it mean?
It indicates poor tissue perfusion and hypoxemia, basically. Tissues aren't getting enough oxygen. Serial measurements of lactate are incredibly valuable for monitoring how a foal is responding or not responding to resuscitation efforts.
Makes sense.
They'll also check electrolytes, sodium, potassium, chloride, calcium, magnesium, and glucose levels. Hypoglycemia is common. Anything below maybe 60, 80 milli-GDL needs attention. And BUN creatinine to assess kidney function. Finally, one more thing. Immunoglobulin G, or IgG, should always be checked in neonatal foals within the first day or so.
For passive transfer.
Exactly. If they have failure of passive transfer, FPT, a plasma transfusion might be needed, and that definitely impacts the overall fluid plan. It becomes part of the fluid therapy.
That's a huge amount of detective work.
Yeah.
But, okay, once all that information is gathered, how do they actually translate it into a specific fluid volume? Because I know it's not just a rough guess, right?
No, absolutely not. It's a precise calculation, or at least as precise as we can make it. Fluid therapy essentially consists of 3 main components that add up to the total daily fluid rate.
3 parts.
Yep. You've got the estimated hydration deficit, plus their ongoing maintenance needs, plus any additional ongoing losses like diarrhea. The percentage of dehydration is estimated based on those clinical signs we just discussed, the mucous membranes, CRT, heart rate, etc., acknowledging the limitations of skin tent.
Okay. Deficit plus maintenance plus losses. How much is maintenance for a foal?
Right. So for maintenance, neonatal foals are quite different from adults. They typically require somewhere in the range of 80 to 100 milliliters per kilogram per day.
So for a 50-kilo foal, that's like 4 to 5 liters a day.
Exactly. Or about 3-4 milliliters per kilogram per hour. Now, to put that in perspective, If you used a traditional adult formula, like the holiday cigar formula,
Yeah.
it would suggest a significantly lower volume for a foal of the same weight. For that 50-kilogram foal, it might only calculate around 2,250 millivelars per day, which is substantially less than a neonatal foal actually needs.
So you'd really undertreat them using adult calculations.
Easily done if you don't factor in their unique physiology. It highlights the difference.
Right. So with all that complex assessment and calculation sorted, you might think the rest is straightforward. But once you know how much they need, the next big question is, what exactly are you putting into these tiny, delicate systems? What's in the actual fluid arsenal?
Good question. For most foals, the workhorses are crystalloids. These are the primary choice.
Like lactated ringers.
Exactly. Balanced isotonic crystalloids, such as lactated ringer solution LRS or things like Normasol R, Plasmolite A. These are typically the first line for hypovolemia, shock, and general rehydration. Their composition closely resembles the fluid found outside the cells, the extracellular fluid, making them ideal. LRS, for instance, contains lactate.
Which helps with acidosis.
Right, the body converts that lactate to bicarbonate, which is quite useful if a foal has metabolic acidosis. Then there's 1.9% saline, often called normal saline. It has a higher chloride content than plasma. Now, while it's useful in specific situations,
Right.
well, it might be preferred if you specifically need a potassium-free crystalloid, say with a uroperitoneum or ruptured bladder where urine is in the abdomen. But using it as the sole fluid in large volumes over prolonged periods can actually worsen things like hypernatremia or metabolic acidosis because of that high chloride load.
So use with caution.
Definitely. Then you have dextrose solutions like 5% dextrose in water, or D5W. This primarily provides free water and glucose, and it's often used as part of a maintenance fluid plan. But a critical caution here. You must avoid giving boluses of concentrated dextrose solutions,
Why is that?
because it can cause a dangerous rebound hypoglycemia. The body overreacts to the sugar rush. Glucose infusion rates need to be very carefully controlled, typically in the range of 4 to 8 milligrams per kilogram per minute. Precision is key.
Okay, crystalloids are the mainstays. What about other types? Colloids.
Right, colloids come in for specific situations like significant hypoalbuminemia, low protein in the blood, or severe hypovolemic shock where crystalloids alone aren't cutting it. Their purpose is basically to increase the intravascular oncotic pressure, the pulling power of proteins in the blood vessels to help hold fluid in circulation and expand plasma volume more effectively than crystalloids can alone.
And what kind of colloids?
Plasma is really considered the gold standard natural colloid for foals.
Why plasma specifically?
Well, it's invaluable because it provides not just albumin, the main protein for oncotic pressure, but also crucial immunoglobulins like IgG, which is vital if the foal has failure of passive transfer. Plus, it contains coagulation factors to help with clotting and anti-inflammatory proteins. So it's indicated for FPT or severe sepsis and shock, especially when the foal's albumin level is low, usually below about 2.5 GDL.
Makes sense.
Yeah.
Are there synthetic options?
There are. Synthetic colloids like hetastarch can be used for rapid volume expansion. However, they need to be used with significant caution, especially in compromised patients.
Risks.
Yeah, they carry risks like interfering with blood clotting coagulopathies, and there are concerns about potential links to acute kidney injury in some cases. So plasma is generally preferred if available and indicated.
Okay. And additives. Like electrolytes.
Absolutely. Various electrolyte and buffer additives might be needed based on the lab results. Potassium chloride, or KCl, is added for hypokalemia, low potassium, but the infusion rate has to be capped, usually around 0.5 milliocucur, to avoid heart problems. Calcium gluconate is used for hypocalcemia, low calcium, but again, it must be administered very slowly, often diluted, to prevent cardiac issues. And sodium bicarbonate might be used for severe, life-threatening metabolic acidosis, but this is used very cautiously and isn't a routine addition anymore. Usually, fixing the perfusion corrects the acidosis.
Right.
And one crucial incompatibility to always remember, don't mix bicarbonate solutions directly with calcium-containing solutions like LRS or calcium gluconate in the same line. They'll precipitate.
Good tip. So it's clearly not just about selecting the right fluid. It's also about how it's delivered. Almost like a carefully choreographed dance, isn't it? What are the specific treatment strategies depending on the foal's immediate condition?
That's a perfect way to put it. It's very much about strategy. For resuscitation from hypovolemic shock, the immediate goal is rapid restoration of circulating blood volume and tissue perfusion. Get oxygen to the tissues.
How do you do that?
Primarily using balanced isotonic crystalloids. But if those aren't sufficient to stabilize the foal, colloids like plasma or sometimes synthetic colloids might be added. The rate is aggressive. We give boluses of 10 to 20 milliliters per kilogram.
Which is how much for an average foal?
Well, for a 50-kilogram foal, that's roughly half a liter to a full liter per bolus. And it's administered rapidly over just 15 to 20 minutes, followed by a complete reassessment after each bolus. Check heart rate, CRT, pulse quality, mentation.
And you might need multiple boluses.
Oh yes, sometimes up to 60 to 80 millimolars per kilogram total might be needed in that initial resuscitation phase. If a foal is still hypotensive, still has poor perfusion after that much fluid, that's often an indication to consider vasopressor therapy drugs to help support blood pressure.
Okay. Anything else crucial for shock?
Yes. Critically, you must always warm fluids to body temperature before administering them, especially boluses. Giving cold fluids rapidly can cause significant hypothermia, which just spirals into more problems for these fragile foals.
Right. Warming is essential. So after the initial shock is managed.
Okay, once the foal is stabilized from that initial crisis, the focus shifts to correcting any remaining dehydration deficit. The estimated fluid deficit is replaced more gradually, typically over maybe 4 to 8 hours for more rapid correction if needed, or perhaps 12 to 24 hours for less severe cases or if there are concerns about overload.
And then maintenance.
Exactly. For ongoing maintenance fluid therapy, the goal is simply to meet their daily physiological needs. Here, fluids with lower sodium and perhaps higher potassium than plasma, like Plasma Light 56, are usually more appropriate for longer-term use.
Why lower sodium?
Because, as we said, foals handle sodium poorly due to their immature kidneys. Half-strength saline, that's 0.45% ACL, often with 2.5% dextrose added, can also be used. The key is avoiding high-sodium fluids like 0.9% saline for continuous maintenance. The rate stays around that 80 to 100 milligram per kilogram per day range, and it's absolutely essential to ensure adequate glucose is provided, aiming for that 4 to 8 milligram per minute rate, often by adding dextrose to the maintenance fluids.
And ongoing losses. Diarrhea, reflux.
Great point. Any ongoing quantifiable losses like heavy diarrhea measured by weighing diapers or gastric reflux volume need to be meticulously quantified. That lost volume should be added volume for volume back into the fluid plan on top of the maintenance rate. And you need to consider the electrolyte composition of what's being lost and adjust additives accordingly. Finally, remember that starting enteral nutrition feeding via tube or parenteral nutrition, TPN, as soon as feasible can also help reduce the overall IV fluid requirements. Get the gut working.
It truly illustrates the dynamic nature of this care. It's absolutely not a set it and forget it kind of therapy. It's constant calculated reassessment and adjustment.
Constantly, yes. You have to be watching them like a hawk.
So speaking of watching, once a foal is on fluids, what's the vigilant follow-up process? What are vets meticulously monitoring to ensure the foal is improving? And crucially, what are the specific risks of this intensive therapy?
Yeah, monitoring is absolutely continuous and incredibly crucial. It never stops. Clinically, they'll check heart rate, respiratory rate, and temperature very frequently. At first, maybe every 1 to 2 hours, then stretching to every 4 to 6 hours once the foal seems more stable. Mucous membranes, capillary refill time, and pulse quality are assessed perhaps even more frequently initially, every 1 to 2 hours. Mentation and the strength of the suckle reflex are often monitored hourly.
What about output?
Vital. Tracking urine output is key. You want to see them producing roughly 1 to 2 millibel per kilogram per hour. Using a urinary catheter can help measure this accurately in critical cases. And daily body weight is essential, probably the best overall indicator of fluid balance. Sudden gains can mean overload.
And physical signs of trouble.
Listening carefully to lung sounds for any crackles, which could signal pulmonary edema fluid in the lungs. And checking for any peripheral edema, swelling, particularly in the limbs or under the belly along the ventral abdomen.
Okay, that's the clinical side. What about labs?
Laboratory parameters are also under constant scrutiny. PCV and TP might be checked every 6 to 12 hours initially to track hydration. Blood glucose needs frequent checking, maybe every 2 to 4 hours, especially if they're on dextrose. Blood gas and lactate might be checked every 4 to 8 hours, or more often if needed, to stay on top of perfusion and acid-base status. Electrolytes are typically checked every 12 to 24 hours, depending on the situation. And B and creatinine usually daily to keep an eye on renal function.
And the catheter itself.
Oh, absolutely. 4V catheter care is paramount to prevent complications. The insertion site must be examined daily, at minimum, for any signs of trouble heat, swelling, pain, discharge, redness tracking up the vein, indicating phlebitis, or kinking of the catheter. For longer-term fluid therapy, which is common in these foals, over-the-wire flexible polyurethane catheters, maybe 14 or 16 gauge, placed using sterile technique, are highly preferred over standard through-the-needle catheters. They tend to last longer and cause fewer complications.
Right. So despite all this careful monitoring, what are the main complications we worry about? You mentioned foals are more susceptible.
They really are. Fluid overload is a significant risk, maybe the biggest one we actively try to prevent.
Signs being
Signs include an increased respiratory rate and effort, maybe clear or even frothy nasal discharge, pulmonary edema, which you'd hear as crackles in the lungs on auscultation, peripheral edema developing in the limbs or ventral abdomen, and, as mentioned, a sudden unexplained increase in body weight. Other risks stemming from the fluids or the illness itself include those electrolyte imbalances we discussed: sodium too high or too low, potassium too high or too low, low calcium. Acid-base disturbances can persist or develop. Hypoglycemia or hyperglycemia can occur from inappropriate dextrose administration. And then there are catheter-related complications like thrombophlebitis, inflammation or clotting of the vein, or even catheter-induced sepsis if bacteria get introduced.
anything else.
There's also the potential for iatrogenic injury harm caused by the treatment itself. For instance, potential myocardial dysfunction, heart issues from a rapid bolus of very cold fluids, or potentially exacerbating pulmonary hypertension in certain conditions. It's a constant tightrope walk, truly.
That's a lot to keep track of. It really highlights how much of a calculated science, and indeed an art form, this whole process is. There's so much judgment involved.
There really is. It's adapting constantly to the individual foal's response.
So given all these complexities and potential pitfalls, is there anything that can be done on the front end, to prevent these critical situations or at least catch them at their absolute earliest stage?
Absolutely. Prevention, or at least very early detection, is incredibly important. The simplest, most vital thing is ensuring frequent nursing.
Just drinking milk.
Yes, frequent nursing is imperative for maintaining normal hydration in neonatal foals. Their fluid turnover is so high they need that constant intake. Any foal that has not been seen nursing properly for, say, 4 hours or longer should immediately be considered at high risk for dehydration. That's a key time frame to keep in mind.
4 hours. Okay.
So, careful monitoring of nursing behavior by owners or stud staff, and meticulously tracking any fluid losses, like scoring diarrhea consistency and frequency, can make an enormous difference in catching problems early and preventing life-threatening hypovolemia before it becomes a crisis.
It really brings it back to the big picture, doesn't it?
Yeah.
That proactive, informed care and just sheer observation are often the best defense against these severe issues. Vigilance from the start.
Vigilance is the word, yes.
Well, we've truly taken a deep dive today, haven't we, into the incredibly complex and precise world of fluid therapy for neonatal foals.
We certainly have. And if we take a step back, I think the core message remains clear. Neonatal foals possess a truly unique physiology. They are fundamentally different.
Not just small adults.
Absolutely not just small adults. And their care demands a calculated science. It requires precision, coupled with vigilant, continuous monitoring to prevent devastating complications like fluid overload. We've seen how plasma, in many cases, proves invaluable, providing more than just volume. And ensuring adequate glucose supply is always essential, given their high metabolic demands and low reserves.
So what does this all mean for you listening in? I think it's a powerful reminder of the intricate, delicate balance within living systems, and how even something that seems as fundamental as giving fluids can be transformed into a sophisticated, life-saving medical intervention that requires incredible expertise and constant attention. And perhaps for our final provocative thought for you to mull over, consider how the sheer vulnerability of these smallest patients, these foals in their first days and weeks, demands the absolute highest level of diagnostic acumen and therapeutic precision from the veterinary team. It's a profound testament, really, to the dedication required in specialized animal care, where every single drop of fluid, every calculation, every lab value, and every moment of observation transforms a seemingly basic need into a true life-saving art form.